It's Sunday night, you're in emergency department and you receive a bad call. The bad call is about a 2-year-old boy who is being brought to emergency in 10 minutes in a cardiac arrest. The second case, the mother brings in her 1-year-old child after being hit by a car. The third case, a father brings in 2-year-old daughter who looks very pale and unwell, and as soon as you take the patient into your resuscitation, she goes into a cardiac arrest. I want you to think about these cases and also imagine what's unique about pediatric arrest. How would you lead the resuscitation to make it more effective? How will you deal with the emotional aspect of yourself as a team leader and the rest of your team? And at last, what do you say in a team debrief? The first case that I saw was last week. It was Sunday night at about 10:30. We received a bad call that they're going to bring a 2-year-old child who is in asystolic cardiac arrest. They've been working on that child for about half an hour to about 40 minutes without an output. There's no pulse and the CPR is in progress. They've managed to put the LMA in. They have gotten IO or interosseous access and the CPR is continuing. Time of arrival would be about 10 minutes. When the child was brought in, we were able to quickly take over from the ambulance staff. We changed the LMA to endotracheal tube, managed to establish a peripheral cannula. We continue on with the CPR. When we received the results of the first venous blood gas, the pH was 6.9, the lactate was 19. The only thing reversible I could see on that was hyperkalemia of 8.8. So we treated the hyperkalemia with the calcium chloride, insulin dextrose, and also gave the child bicarbonate because of the severe acidosis. We continued with the CPR for the next 20 minutes without any return of the output or pulse. Further information about this child was that he'd been unwell for about a couple of days, but not too unwell, has been eating and drinking, has been sleeping well, has been playing. In fact, had been to the children's park that afternoon. When he was put to the bed by the father, and after about an hour, he was face down, not breathing, unresponsive, no pulse, and at that point the ambulance was called. This child had already received about 40 minutes of CPR from the paramedics and another 40 minutes of CPR from us. We initiated a discussion about any other reversible cause that may have been overlooked, but we were not able to find any. I went to the parents and told them honestly that this is looking grim and their son is unlikely to survive. The parents somehow appear to have an understanding already. We stopped the CPR. The parents were very distressed. I stayed with the parents for about 10-15 minutes. The father actually turned to the team and thanked everyone, shaking hands, that under the circumstances we did whatever we could to save the poor child's life. After about half an hour, we went into our debrief room. We had the pediatric consultant, anesthesia consultant, we had the intensive care registrar and rest of the junior doctors from emergency. The team debrief is all about thinking if we could have done anything differently which would have made any difference to that resuscitation. We identified that it was very unlikely. The child was already found unresponsive, had a good quality CPR from that period of being found for 40 minutes by the paramedics. We took over the resuscitation and without any interruption continued on the CPR for further 40 minutes. We did identify one episode of hyperkalemia that we reversed, and repeat venous blood gas did show that it improved to about 5.6 without any improvement in the clinical output or any return of the pulse. Last year in December, I was in the hospital in resuscitation and I heard a woman screaming outside the resuscitation area. When I came out to see what's happening, I saw this young woman with a child in her arms who was completely flat and limp and appeared to have this very nasty looking head injury. I immediately took the child from the woman's arm and took her took the child into the pediatric resus area, took over the airway and pressed the arrest buzzer. Within about 5 minutes, I had about 4 emergency consultants. We also had trauma consultant coming in, the neurosurgeons, the anesthesia and the intensive care doctors. The history was the child was running onto the driveway and the father was reversing the car and accidentally ran over the child. The father came out of the car, was in shock looking the child in this situation and started to scream. Mother came out of the house, scooped the child, put the child in her lap and self-drove to the emergency department and then was quickly moved from triage straight to the resus. That's when I found the child. It looked like the child had pretty nasty head injury. He had a large frontoparietal occipital hematoma, tire abrasion marks onto the face. We were able to establish the airway pretty quickly. The child had an output, had a pulse of about 200 and the blood pressure about 90, so did not require a CPR at that point. From the neurologic point of view, the child had a dilated left-sided pupil where the hematoma was. We called in the neurosurgeons who came quickly and reviewed the child and said that keeping in mind that this child has been run over by the car, has got a large frontoparietal hematoma and a dilated non-reactive pupil on the left side, it's an unsurvivable brain injury. The chances of this child making it through, even with an operation, are very, very low. He's going to either rest here or on the operation theatre table. Because the child was stable, we were getting ready to take him to the CT scan to find out what else is going on. Child went into a cardiac arrest. He became bradycardic to about 30, 20, and we lost an output. We started the CPR. We had already given the child the hypertonic saline from the head injury point of view. We continued the CPR for the next 40 minutes. Unfortunately, we were unable to save that child's life and we pronounced him dead at the end of that resuscitation. The parents were there, seeing all our efforts, both the father and mother. That was their only child. And to make the matters even more emotional, that was the child's first birthday on that day. So a terrible, terrible accident, which happens so commonly still in many parts of the world. So be careful out there. We then convened for the team debrief. The emergency consultant, who is my friend, who led that resuscitation, actually broke down and started to cry. We went through if we could have done things. There was someone who mentioned that could there be a possibility, even for the sake of argument, that we should have taken the child straight to theatre and have that presumable large subdural, extradural and skull base fracture relieved to have any meaningful outcome in terms of survivability. The answer by the neurosurgical consultant was that in terms of mechanism, being run over by a large SUV, 1-year-old with a fixed and dilated pupil, that child had already coned and the cardiac arrest was imminent in the next few minutes. That's exactly what happened. The third case that I saw was when I was an emergency registrar. I had actually just started in Australia. It was nearly about 13, 14 years ago. It was a Saturday morning. A father had actually taken his 3-year-old daughter to the GP first. She'd been unwell for about 4 days now. It was a review. The GP said, look, she's not looking too well to me. I would suggest that you take her to the hospital. The father strapped the child in the back seat of the car and was talking to the child. But halfway through the journey, the child stopped responding. The father parked the car in front of the emergency department, took the child, gave the child to the nurse and said that she's not talking to me. She was just doing that about a few minutes ago. I was actually in the resus with another patient, a young 40-year-old with chest pain. We quickly moved that patient out of the resus and took this child straight onto the bed. To me, the first impression was that the child was almost as if she's having a seizure. I thought maybe she's having a febrile convulsion because she felt warm. So I asked the nurse to get me some midazolam. But then I felt the pulse and there was no pulse and there was no breathing effect. So we just immediately hit the arrest buzzer. Within about 5 minutes, we had the pediatric consultant, the emergency consultant who was on the floor, was already there. We quickly established the airway and started the CPR. It was an asystole. We continued on the CPR for about 1 hour on that child without any form of return of spontaneous circulation. We pronounced the child dead at the end of the resuscitation. The father was there. The mother had arrived. They were distressed because it was completely unexpected. I was emotionally distressed to the core because I had never witnessed a pediatric cardiac arrest by myself. As a junior doctor at that point, there was no help offered to me. Unfortunately, we did not have any warm debrief at that point as to what had actually happened. A few weeks down the line, the autopsy revealed that that 3-year-old child had myocarditis, so must have been unwell with upper respiratory tract infection. In the first case, we had advanced notification, 10 minutes prep time. In the second case, we did not have any notification or preparation time. Same goes for the third case, but we were able to deliver an exemplary resuscitation even with a very short notice or no notice at all. I think as a team, it's very important in pediatric resuscitation for one member to be assigned to the role of the team leader. So they're just thinking unidirectionally, engage with all the aspects of the team members, all the aspects of the resuscitation. The airway, the breathing, the circulation, the primary, secondary surveys, what needs to be done next, what is done and is reversed, a closed loop communication at every level. And when you're making a decision to stop the resuscitation on a pediatric patient, it's a very sensitive issue. Make sure that you invite everybody's concerns and inputs at that point. A medical consensus. Involve the parents in that decision as well. And when you do that, make sure the monitoring's turned off. The child body is looking decent. You've got social worker there. You're sitting there with the parents to provide them help and support. It's a very, very difficult situation. Let me emphasize that. And after that, you've got even a bigger responsibility. You need to do a warm debrief. What went well? What could we have done differently? All that needs to come out at that point. It's a difficult situation. No matter how many times you've run a pediatric cardiac arrest, it always feels that you're doing it for the first time. So look after yourself, look after your patients. Whenever you're doing the pediatric resuscitation, make sure that you're doing everything that you can to save that poor child's life. Even though you may think the outcome is going to be poor, give it your best shot. Thank you very much. Look after yourselves.